bits. So as I said, welcome. I'm Kirsty. I am a GP from Truganina and one of the co-facilitators of the community of practice. Welcome if it's your first community of practice. We hope you enjoy it and find it valuable. The title is Improving Childhood Asthma Management, and this is the back to school session. So we did this last year and it was well received. If you are working with the Department of Education or within the community, I'm sure you are familiar with this time of year and how tricky it can be with asthma plans and kids. So we'll cover a broad range of case studies with common issues in childhood asthma that relate to the school setting, and then go through a bit of exercise-induced asthma and the asthma plans. I'd like to start the meeting with our acknowledgement of country. In the spirit of reconciliation, we acknowledge the traditional custodians of the land on which we meet, the Wurundjeri people of the Kulin Nation. We pay our respects to the elders past, present, and extend the respects to all Aboriginal and Torres Strait Islanders people today, for they are the safekeepers of memories, traditions and culture. We recognise their connection to country, land and sea and community, and the role in caring for and maintaining country over thousands of years. May their strength and wisdom be with us this evening. So just a bit of housekeeping. If you can keep yourself on mute and you can ask questions via the chat box, I'll ask our back of house staff to keep an eye on the chat and my co-facilitators. We bring questions up as they come or at the end of each case study. We are quite informal. If you want to speak up, just raise your hand and we'll try and ask questions that way as well. If you feel more comfortable just using the chat, that's fine. The session is being recorded and you'll have access to the recording via information that will be emailed to you afterwards. And please ensure when you join, use the session name that you registered with so we can mark your attendance if you're applying for CPD points. That's just how to change your name in the Zoom meeting. Click on participants, the app, click your name, desktop, hover over your name, and Mac, hover your name and click more, and then rename and use the name you registered with. So the agenda is welcome and intros. I'll be going through the case studies and then we'll have our respiratory asthma specialist from the RCH, Shiv Shantakumar, to talk a bit about exercise-induced asthma. And then I'll be going through asthma plans in a practical way. We're talking a little bit about a very productive meeting we had with the Department of Education a couple of weeks ago. And then we'll run through health pathways and how to access the community asthma programme service. So by the end of the session, we hope that you'll be able to implement best practice for the management of asthma in children across all ages, describe resources and local services that you can use for children in the West living with asthma, and identify collaborative multidisciplinary opportunities to improve the care for children living with asthma. We have a little bit of local data on Shiv's slides for you to interpret. So if you'd like to, as I say, it's a huge participation this evening, but if you want to introduce yourself on your chat, please pop in your name, your organisation and your role. It gives everybody a nice idea of the spread of attendees. We will have some client and patient participants this evening as well. So when you're putting in questions, speaking, just remember to use plain language. Thanks. So as I said, I'm a GP from Truganina. We see a lot of asthma and allergy out our way, as I'm sure you all do. And I have special interest in paediatrics. Shiv is the paediatric respiratory specialist and leads at the RCH, and he is a clinical scientist fellow as well. So we'll kick off with case studies. Some of these might be familiar, and they're ones we've used before that have been developed as their clinical presentation have developed, and they're just the most relevant to highlight asthma in each age group and particular nuances with confusions and differential diagnosis. So we start with our bubby, a wee 2-year-old who came in and he's got a viral irritability, and mum's already been given a Ventolin spacer by somebody else, and she has a mask at home and she's using it every 4 hours, she says, 4 to 6 puffs, because he's having increased worker breathing and respiratory rate. Listen, he's got a wheeze throughout his chest, and mum says she gave him 6 puffs, good technique, 2 hours ago at home. So we give him 6 bursts in practice, and he's improved, but he's still wheezy. So we ask a little bit more history about this young chap. Mum says he had multiple admissions with bronchiolitis under the age of 12 months, and he was first given Ventolin by the emergency department at 14 months, and he was discharged with a spacer and a mask. In the last 10 months, he's had 3 emergency department admissions, 4 oral steroids in oral courses of steroids, so 4 lots of 3 days of steroids in community and from emergency. He's had 2 oral antibiotic courses, and he's had wheeze and every respiratory tract infection almost monthly, and he's gone through roughly 2 or 3 Ventolin inhalers. He's not been given a diagnosis. He's been told by all clinicians she's seen that he's too young to say he's got asthma, it's just viral infections. Therefore, she's not been given any formal asthma education. There's been no asthma plan for his daycare or asthma device education. He's got a history of eczema, and he's vaccinated apart from influenza, and they don't have a regular GP. He's never been tied in this summer. He lives with mum, dad, and his 3 siblings. Dad's got very poorly controlled asthma. Both parents vape and smoke outside the home. They don't have any pets, no food allergies, and no reported environmental triggers that they can think of. So just looking at the chat, does anybody have any more questions or thoughts about what you're going to do here? I usually give it a few minutes. It takes about half an hour for most people to warm up, so I'm happy to move forward if nobody wants to put anything in. Any further questions you might want to know about this child? Okay, I'll take it that my case history has covered everything really well. Okay, so we'll move on to what we did next. Okay, so we made the diagnosis of asthma. First up, this is a kid who responds to Ventolin, has clear asthma symptoms, and has had multiple admissions and treatments in the community, high doses of oral steroids. This kid's got asthma, so we're very clear, even before we pop them off to secondary care, that this is asthma. Make it really clear to parents in this situation. They need a diagnosis, so they know how to manage it, and there's no confusion. And we get this consistently back from our clients, from our patients, and from other healthcare practitioners that work in the community, that these little ones, once you make the diagnosis of asthma, it's much easier to communicate and treat children. It's also the appropriate diagnosis.
Kirsty, I'm just going to quickly, sorry, 100% agree with everything you said. Just Jacqueline has asked a question in the chat about whether he's has a history of prematurity.
No, he's not an ex-premi. Totally, thanks for that. Yeah, obviously ask the perinatal and neonatal history. Absolutely nothing exciting at all.
And just in support of what you were just saying about making the asthma diagnosis, if you ever, I know there's like a lot of sometimes you need something to support that, as in, if you're a nurse sending someone back to their GP, or if you're a GP communicating with a regular GP or something like that. And the RCH preschool asthma CPG is quite clear on making the diagnosis, and that you just need 2 episodes of Ventolin responsive wheeze to call it preschool asthma. So if you need a resource to back up exactly the points Kirsty's making, that might be helpful.
I think that's really useful as well, just to know, because we've all seen a little bit of wheeze and a cough or cold, but number 2, that's it. Strike, we're calling it asthma. We've gone into more detail on this, so if people have questions like that around that diagnosis and evidence, there's a lot of new information on the RCH you can look into. We maybe have time to answer it later. There's always lots of questions about the preschoolers. So we write a letter to the ED department outlining the current situation and the past medical history that we've made the diagnosis. So he has burst therapy, some steroid, he's admitted for the PEDS ward, and the diagnosis is communicated through all the department, from ED to the PEDS to the asthma nurse in the ward. This is asthma. So mum's got a much clearer idea of what's going here, and it's been corroborated by all healthcare professionals involved. He has started on a preventer, Flixtide Junior 1 puff twice a day, because he has recurrent severe asthma, and he has had a high oral course of steroids. And we make him an asthma plan. He's referred to the community asthma program. For people who are unfamiliar, this is a nurse and specialist nurse led program Our local one is run by CoHealth in Laverton, and it is a comprehensive asthma follow-up for any child under the age of 18. It's a free service. They get roughly an hour with the nurse practitioner as many times as they need. They can also go home or to school or daycare with the child to give education in those settings. And then follow-up GP appointment was made prior to discharge. This is really sort of gold standard asthma care. Consolidated education and all the follow-ups made for a brittle asthmatic starting a preventer prior to discharge. The discharge paper was given to mum and dad and it was sent to the GP. And they were advised on Ventolin weaning. Ventolin weanings are an interesting thing. Shiv, do you want to talk a little bit about the difference between weaning Ventolin and a Ventolin weaning plan?
Yeah, so it's an area of controversy amongst in the asthma world. But so when someone has an asthma exacerbation, as Kirsty's often said, and as you would all know, often in ED you start with a burst therapy. So that's like Ventolin given 20 minutes, every 20 minutes for the first hour. And then gradually it's spaced out, 1 hourly, then 2 hourly, and generally around the 3 hourly mark is when the patient can go home and continue care at home. And in general, what the message we want is that children should get Ventolin when they need it. So for some kids, that might be initially every 4 hours at home, and then it will gradually space out. But hopefully during the admission, parents have been taught how to recognize the symptoms of asthma and when to give Ventolin. So therefore, they can just give it when needed once they go home. There used to be this idea that parents couldn't manage that. And so therefore we need to give them a strict plan of, say, Ventolin every 4 hourlies for the first day, then 6 hourly for the second day, and then 8 hourly or something for the next day. So that's a weaning plan. And in general, a lot of us think they aren't appropriate because it's kind of missing the point of Ventolin being given when it's needed and families being taught how to do that. And so, yeah, that's the kind of tension.
Yeah, and I think it's really useful to know and to explain to patients. I still certainly see people coming out on Ventolin weaning plans. And for me, the crucial information I try to get across to them is they miss the signs of worsening asthma if they're not in tune to it. But also, if you're giving a child 4-hourly Ventolin when they don't need it, they actually need 8-hourly Ventolin, and then they deteriorate to need 4-hourly Ventolin. You've also missed that. You've missed the point of seeing that they've gone from 8-hourly Ventolin to 4-hourly Ventolin. So it can protract the time at home and lessen the time heading back for more advice or more intervention. There's also side effects of giving far too much Ventolin. You go through a Ventolin inhaler pretty quickly if you're giving it every 4 hours for the first 2 or 3 days post-discharge. So again, we've covered this in other community of practices. So sorry if you're new. I know there's a lot of new attendees today. If you want some more information, we can attend to that at the end. So when he comes back to the GP, we arrange a long appointment. We have our post-discharge appointment. We have a long appointment for the GPs in the room. This is the point you can use your chronic disease management plan and your team care arrangements to get the extra time you need with this patient to clarify questions. And you can use the pharmacist, daycare, the community asthma programme, the hospital, if they're doing review, to add to the team care arrangement, asthma educators. And then when we do the asthma plan, we'll show you the plans later on and go through the practicalities of it. For a child like this, I would do an asthma plan with a review day of 6 weeks. Now, bearing in mind the asthma plan is a clinical plan that pertains to the child's health needs. It is not a document for any other purposes. This can be tricky, especially for daycare centres for children this age, because it means that they will have to come back in 6 weeks to review the plan. Now, we'll talk about that a little bit later and interesting information we had from the Department of Education with regards to attendance, and I'm sure a lot of the messaging that many people in the community get around this. So we put a review date for 6 weeks and we arrange an influenza vaccine. The other thing that we say, which is useful for the family, is the Victorian Virtual ED service. If you've not used it, you can Google VVED. They have to have access to video conferencing. So any any modern mobile phone can do that, and they will be assessed by a paediatrician, and they actually have a virtual asthma ward. So if parents are struggling in the middle of the night, not sure whether to go to ED, they can put them in this virtual asthma ward, watch them give burst therapy at home for parents who are experienced enough and comfortable enough to do so, and then check in on them at the appropriate time interval to save admission to ED. They obviously also say if a child isn't well enough, you have to head up to an ED. I advise in a child like this to come to the GP each time he is unwell with a cough or a cold, so that they don't miss wheeze and don't miss symptoms. That usually happens for the first few months, especially if they're getting an RT every month. And then things relax, parents are more confident, and I'm more confident in their ability to assess, and we only see them when we need to. And we have a pharmacy on site, so I use pharmacy to help educate with the new inhaler if they have any questions and they can't get in with me. So he was seen by the community asthma programme the following week. He was seen every respiratory infection for 3 months, and he had further wheeze with each episode with no admissions. He was managed just with Ventolin increased in the community, but we did have to increase his Flixotide to 2 puffs BD because he was still uncontrolled, having multiple exacerbations. So he remained with really good control on this dose until the following winter. So he's now 3 years old. He's getting wheeze every month with viral infection again in winter, and he's had 1 ED admission now and some oral steroid. The parents are still smoking. He's continuing to engage with the community asthma programme and the GP. I've updated the asthma plan for school and updated his care plan in practice to reflect that he is now on Flixotide 2 plus BD and the ongoing engagement. But you've got a kid who's still got pretty bristle asthma. He's now had another admission. So just to ask, what are your next steps now? Are you thinking, are we going to start an oral agent, Montelukast, or are we thinking that we need some more support? So I'll put that to the chat. Does anybody need some more information? What do you think your next steps are going to be? So Jessica Handrick sensitively discuss smoking with parents. Yep, absolutely. First steps, we're going to have to talk about the smoking. The answer, unfortunately, is they're not going to quit. Social situation is very difficult. It's just not within their remit right now. Very concerned, appropriately attending with the child, but they are not in the position to quit right now, unfortunately. Any other questions? Allergy testing, yep, Michael, brilliant. So yep, we've got our case study in allergy, so we'll go through a bit more about that, but absolutely, we will think about allergies. Is there other triggers? Deb is asking what's the adhere times, the Flixotide and technique. Okay, brilliant, actually. Really engaged parents, apart from the not stopping smoking, but we all know everybody has difficulty with this, and there's other complexities that happen in life. But yeah, really engaged, really good. Anything else?
I was going to say that's the advantage of one of the advantages of that approach you've got of them having come back so frequently for those exacerbations initially, where maybe they could have managed them at home, but now you've really reinforced like how to give the medication properly and had a chance to address any technique issues and things, so you can be more confident of that assessment.
Yeah,
like kind of set them up from the start for success.
And Michael again saying, a brilliant question. What age can respiratory function tests be accurately done? And Susie, does there need to be adjustments to the medication regime? So, yep, we might need to do something about the medication, Susie, absolutely. I'll let Shiv speak to that in a second. Pulmonary function tests, really, it depends on the child, but I wouldn't be referring them before about 8. Would you agree with that, Shiv?
Yeah, well, there's two aspects to answering that question. One, how helpful will respiratory functions tests be, even if they can do them with good technique? And 2, yeah, what is the age at which kids can reliably do it? So in terms of how helpful would they be? So I think respiratory function in asthma is helpful when you're not sure of the diagnosis, which can be a hard diagnosis to make. But in this case, I think because Kirsty's seen acute symptoms of asthma that have responded to asthma therapy repeatedly and like assessed that in person. I think you're very clear on the diagnosis. So I actually am not sure that lung function tests help you that much, even if the child can do them. Because what you really need is something that's going to lead to better control as opposed to questioning the diagnosis. In terms of, yeah, so kids can kind of start doing them around the age of 6, but it's probably around the age of 8 that you're going to get reliably useful results. So it's probably, yeah, not worth doing. And I would say that they're best, I only trust them if they're done at a pediatric lab. So whilst many GP practices can do spirometry for adults beautifully with great reproducibility, the kids are just different. So, yeah.
So if you're looking to refer for a pulmonary function test, the Royal Children's really is the place to do it. The private providers don't do it. And their wait list, I find it pleasantly surprising in terms of outpatient wait list is pretty good.
Yeah, if you're just getting the lung function test done, they can get people in very quickly.
Yeah.
Yeah. And if anyone who's down Monash Way, I know this is mainly Northwest, but if you are dialing in from Monash Way, Monash has a lab too.
We talk a bit more about respiratory function tests in an older patient as well. And in terms of medication, medication regime, yes, the only thing I would do myself right now is pick up the phone to our lovely community asthma program nurses who are incredible, and maybe get them to have another session focused on environmental triggers. So say, would they be willing to do a home visit to have a look at the home? Some people don't realise there's damp in the home or there's inhaled allergens. Asking about pets as well. Definitely do allergy testing if there's pets or a new pet in the home. And maybe speaking to daycare just to see how compliance and treatment are triggers there that might be that they don't know. It's not really practical, it's not something I can do, but the correct me community asthma nurses if that's changed, but they do have the resources to be able to make visits to the community for some patients. So if we decide, so I start Montelukast on young patients, but with this kid, he's a pretty active young boy. He's definitely a sweetheart, but a handful. And I felt that he probably would benefit from just having a second set of eyes on him to talk about whether Montelukast was appropriate or whether he needed to go down the pathway of biologicals later. And I just felt he's very brittle. I would quite like him under the respiratory team. What would you do when you see a kid like this, Shiv?
Probably go through everything that you've talked about, just like 1, confirming the diagnosis. So looking at notes about that. 2, trying to assess adherence and technique as much as best as possible, but eventually getting to the same conclusion with medications. I think I'd offer the parents Montelukast, or sometimes I offer them a combined ICS LABA like Symbicort, which is kind of off-label use, but I guess that's one of the things about just seeing a lot of asthma is you get comfortable with that. With Montelukast, I do preemptively talk about all the potential behavioral side effects. So what I say is about 1 in every 15 to 20 kids will get a change in their behavior. That could be a change in mood, irritability, defiance, nightmares, difficulty sleeping. If you Google it, it will come up with links to suicide, which is very scary to read, but we don't think is a true link. But the change in behavior definitely is something that we see. So after kind of explaining all of that, some families just elect that it's not for them, and that's okay. We'll probably go down the Symbicort route. For those that do elect to give it a go, I think for some kids it works really well.
Great, thanks so much. And Deb is just very helpfully saying that Sunshine only does respiratory function tests over 13 years. So the RCH is your port of call if they're younger than that. Right, I promise that was the longest case study. With preschoolers, there's a lot to go through, so we'll try and rattle through the others. So case study 2, this kind of centralizes on preventer therapy in a slightly older child. So you've got a 5-year-old female attends with mum and dad. It's her 3rd winter of asthma. So to go back in time, she was diagnosed with preschool asthma when she was 3 years old. She always has a viral trigger. So she's always having asthma symptoms when she has a cough or a cold. There's no other environmental triggers, no family history, no symptoms in between times. Her first presentation were back-to-back hospital admissions requiring burst therapy and oral steroids. and she was diagnosed in hospital and given the Flixotide at the RCH. She was referred to the community asthma programme on discharge, and after 2 or 3 months, family are really adherent, child's doing brilliantly, so she was discharged from then, and the community asthma programme actually referred her to me as an ongoing regular GP. So she's really well through spring and summer. She's not used her Ventolin for almost 6 months since she was put on the Flixotide. And at this point, if you have a child who's been completely asymptomatic for 6 months, a very clearly defined trigger of cough and colds, no other atopy, allergies or risk factors, I'm weaning off the Flixotide at this point and seeing how she goes. Episode late summer, but they weren't really sure she was wheezy, actually. This is off the Flixotide now. So they used the Ventolin, but they weren't really sure if it was asthma or not. And then, unfortunately, as it turned into winter and she started picking up more coughs and colds, she started coming in with more wheezy illnesses. She came in with 3 altogether, requiring regular Ventolin for up to 5 days over a 2-month period. She always had some wheeze and an asthmatic cough, but she was never unwell enough to go to hospital or require any other therapies. So we started her back on her Flixotide, just 1 puff twice a day this time, on the 3rd episode. So she's been unwell the previous winter, been on Flixotide, been symptom-free for over 6 months, so we stop it. A few months later, it's winter, she starts to have coughs and colds again. Concertina, the same the way they were, always has wheezy symptoms. She's come in, I've auscultated, I've heard it, I've seen it respond to Ventolin. We know what happened last year. She's heading towards admission. You're back on your Flixotide. And she did really well. So she responded really well. We increased it after a couple of more sessions. So she went a couple more episodes. She went back up to 2 puffs. And we referred her back to the community asthma programme. We have the resource there. Family were just feeling a bit twitched. She goes back there, refreshes their education and their understanding. They're discharged. And again, she is totally well. Over spring, summer, we wean down her Flixotide. So 3rd winter, as I said, she's 5. Perhaps again, loose history of a flare in summer, but we're not very convinced, and the parents aren't very convinced. But otherwise, she's been totally well. I have not seen her until she's come in again, cough and a cold, asthma, in about May. So she's wheezing, she's coughing, she's responding to Ventolin. What would you do? So while you're putting in any other questions, you've got a child who's in her 3rd winter of asthma symptoms, completely well the rest of the year, weans off her preventer and remains symptom-free until the cold weather comes and she gets coughs and colds again. Do you, on this episode, immediately start her on her Flixotide? Do you have a conversation with her mum and dad, or do you watch and wait? Anybody want to go out there? Okay, everybody's here we go. Susie, I would strongly consider starting medications. Yeah, put an asthma plan in place. Perfect. Restart the preventer. Okay. Takes a while for everybody to get flowing, and then it comes. Okay, everybody's feeling confident now. Ask if any change in the environment. Yep, go through the history, see if there's anything else. Can the Flixotide or something else be started preemptively in April or May? Yep, break over summer, brilliant. Has she started school? Great. Probably start the seasonal preventer. Great. Okay, so we're all getting the same sort of thoughts. Yeah, we know this kid is the cold weather, and that in association with respiratory infections, she gets asthma again. We've been here twice before. She's not grown out of it yet. She's definitely still asthmatic, so we're starting her Flixotide again. What do you feel, Shiv, for winter and cough and cold asthma as opposed to allergic asthma being started preemptively in April every year?
Yeah. Oh, yeah. I'm just going to quickly say, I think this is a beautiful case that highlights the value of like a longitudinal approach to asthma. And you know how we always say, like, continually reassess and step up and step down on preventers as appropriate, as opposed to just managing each acute exacerbation as an individual episode with some prednisolone or something. So I just think that this really nicely highlights that. In terms of I'd be pretty keen to, as people have said in the chat, about starting someone on back on an inhaled corticosteroid. If like flitzitide, if a family said to me, we really like, maybe they've grown out of their asthma, we really want to wait to see what happens with it. If there's another exacerbation, I guess I wouldn't like think it's such a high risk that I'd be kind of trying to force them to start the preventer, but I'd really be trying to sway them to restarting it. And also if they said, oh, and I think the option of kind of preemptively starting is quite reasonable too. And in general, I think, inhaled corticosteroids take at least 2 weeks, probably about 6 weeks to have maximal impact. So if you do want to preemptively start something, that's the kind of time frame you need to start it with. And Susie, I think that idea of viral induced wheeze versus asthma is really tricky, isn't it? And I think when you call it viral induced wheeze, it kind of lends to just management of acute episodes. So that circles all the way back to one of the very first points that Kirsty made about the importance and the value of a good diagnosis, setting people up for good care moving forward. So yeah, would be very supportive of people diagnosing asthma.
So with this child, the parents are really steroid phobic. They are really just still in their heads. They've had lots of education. They're really engaged. They're fantastic parents and patients, their dream, but they still are really worried about inhaled steroids. And they say, Kirsty, do we really need to start it? Can we give her a bit more time? And I know they're a bit steroid phobic. We've had this chat before. They're very kind of open about it. And there's two things that I use in clinical practice. One is she has already had, I'm gonna have to tot it up in my head, I think 3 or 4 courses of oral prednisolone for 3 days. So she's about 12 doses of oral prednisolone. So the way I quantify it to parents is, I know the thought of your child being on an inhaled steroid for 6 months is a lot, but actually that's only half of 1 day's oral dose equivalent. And we double check this with our pharmacist. It's about that. A year's worth of inhaled corticosteroid is about the same as an oral course of prednisolone. So it actually prevents more steroid side effects. I also go through the side effects of long-term inhaled corticosteroids, so oral thrush and perhaps a little bit height loss if you're a very brittle asthmatic and you're taking it your whole life. Otherwise, not much really. And versus oral steroids and getting to that critical threshold of oral steroids where you can't really go back from, and the risk of cataracts and osteoporosis and diabetes is there. And a lot of kids that I see have had 10 courses of oral steroids in the community. So it's not, she's obviously not there yet, but it's not insignificant sometimes. So I really sort of educate around the steroid, and I really persuaded them, I think we should try one puff. She's getting better every year. I'm pretty sure she will go out of this. There's no family history, there's no other environmental factors, but I think she does need it again, and they were pretty accepting. And again, Susie, to your point of viral induced wheeze, I really try to re-educate around asthma is asthma. A diagnosis is recurrent wheeze responsive to Ventolin, full stop. We don't need, it doesn't matter what the trigger is. Some kids are only triggered by spring. They've got seasonal asthma. Is that spring asthma? No, it's asthma. Yes, we do call it allergic asthma, seasonal asthma, but we still call it asthma, not seasonal induced wheeze. It's just very confusing, and we've had some really nice examples from parents of children and some of our working group explain how confusing it is to be told by multiple different healthcare professionals, this is asthma, it's not asthma, it is asthma, it's not asthma. If it's asthma, we can treat it as asthma, which is what it needs to be. We can do an asthma action plan. We can communicate to the school, it's asthma. Yes, you can grow out of asthma. We know asthma is a relapsing and remitting condition. Children go out of it. They also then represent when they're 27 with asthma again. So really explaining the longitudinal illness of asthma, and that is the diagnosis. So yes, you're right, we do need to do the asthma care plans, which we'll get on to. So case 3 is allergic asthma. So we've got a little 8-year-old girl, and she's got mild asthma. She's got cough, sneezing, itchy eyes, and rhinorrhea in late October in West Melbourne. And she's increased into her Ventolin use for her nocturnal cough and the dry cough she has when she comes in from outdoors. But she hadn't really had any asthma symptoms for about 8 months prior to that. The last she had was late last summer, about this time. She's never been admitted, no oral steroids, no antibiotics. She's got an egg allergy, she's got eczema, and we know she's got hay fever. She's never had a preventer, and she mostly uses Ventolin in the spring season when she needs it, mostly for cough. They're non-smokers, they don't vape. She does have a cat at home, and she's well. She doesn't have any wheeze or any other examination findings. And they've come in really because they also need an asthma plan, thinking about school next year, and the allergy plan for her egg at school. So it's a can I have my plans, but I've got a few symptoms, doc, sort of consult. So any further questions for this kid? Anybody want to know anything else? Okay, I'll start with one thing. Asthma plans. Why have you come in for your asthma plan in October? It's usually end of school year. She had her asthma plan done by somebody else, and they had put a review date on it to review it in spring, and it's out of date. And the school's just noticed, and they said she can't come back to school and she can't go on camp until she's got her asthma and allergy plan. So we'll talk a little bit about that and that scenario later on in the slides. But that's the other reason why they're quite urgent, and they just want the plans and to get out of there. So a few people saying immunisation history. Yep, she's fully immunised. Is her egg allergy anaphylaxis? Let's say yes. Honestly, I can't remember. Let's go yes. It is anaphylaxis. Okay, we'll move on. Okay, so with difficulty ascertaining how much of the symptoms were asthma and whether there was a response to Ventolin. She's got a really snotty, irritated nose, and she's coughing a lot. Is it just postnasal drip? I've not heard wheeze. She's not really coughing in consult, so I can't see if there's a Ventolin response, but we definitely know this is a very atopic kid. So she's never had severe asthma though, okay, but she's very atopic. So we talk about it, and usually my response here is I see so many people using Ventolin when they maybe don't need to, and so many people not using Ventolin when they really need to. But I've never seen this kid particularly asthmatic, and she's not got any concerning signs, but she definitely needs her allergies controlled. So we do the allergy plan. And sorry, we do the allergy plan. Yep, that's fine. That's easy to do. We start a twice daily oral antihistamine of your choice, a nasal steroid, and as required eye drops. Okay. And then I want some more information about this asthma. I've got a 10-minute appointment that's already run into 20, so I'm referring her to the community asthma program. They are the perfect people, great communication, fantastic clinicians to go through with this girl for a whole hour. What is going on? Is it asthma? What do I do with her asthma plan? Well, at the moment, she still only needs Ventolin, so I redo it just for the Ventolin at the moment and put a date for the end of the year. So it's not running into the next school year, just the end of the year to tide her over. And as we'll talk about with the Department of Education, I write a letter to the school to explain that nothing's changed with her asthma management, that asthma plans are valid until they're superseded, and you cannot exclude a child from an education setting based on health grounds, because that's self-discrimination. I don't add that bit, but it is health discrimination. And really the only acceptable time to not allow a child to go to school is if they've obviously had a serious major health concern, like new epilepsy, and they're about to go on camp and the school have no idea how to manage this. Or acute severe asthma that's just been diagnosed, and again they're about to go to camp. If this is a kid who really never uses their Ventolin at school and is very well and nothing's changed, they're allowed to go to school until the family have had a chance to get to the GP. So we see her 2 weeks later. She's not used her Ventolin at all, actually. Her symptoms are really well controlled, no hay fever symptoms. She's had brilliant education with regard to Ventolin use and when to use it, when not to use it. We do a care plan because she's under an allergist, she's under the community asthma program. And I keep on saying this for people who aren't specifically GPs or working in primary care, because asthma is one of the first things listed on a chronic disease management plan, but it's very hard to meet the criteria. And I find most asthmatics will have an asthma plan, but not a chronic disease management plan. And if you want the time to be able to see these kids and the remuneration that goes with that, they need a chronic disease management plan. But also, as opposed to having all these separate allergy and asthma plans, they then have one document that actually has everything together when they go to hospital, as opposed to the parents trying to grab their allergy plan, their anaphylaxis plan, their hay fever plan, their allergic rhinitis plan, their eczema plan, their, 5 or 6 different plans for an atopic kid to explain what they're on. The care plan has it all, as you'll know if you've seen them. So she's doing really well, but then November comes, thunderstorm asthma time, and she's admitted with acute asthma. She gets oral steroids, she's got a bit of an oxygen requirement, and she stays for a couple of days. Any other questions at this point? I think I answered all my questions. Asthma plan in school, sorry.
I was just going to ask Kirsty, what's the eligibility criteria for that chronic
So
disease?
they need to have a chronic disease, so it has to last or be likely to lasting for 6 months or more. So if you've got diabetes, you don't need to wait 6 months. It's there, it's diabetes, even if it gets better and worse. And you need to have a GP and 2 other specialists involved. So that would be her allergist and the community asthma plan. It could be the pharmacist if they go back for inhaler reviews, if you have that, and the community asthma program. Involving schools and daycares is difficult. Technically, if they have an asthma plan and they're providing care for the child, they're providing care. The sort of guidelines is very grey. I've not used it with just an education setting provider, but I definitely have kids who have had the education provider on the care plan because it's appropriate to do so. Cool. Autism, for example, their school would be involved.
Okay.
Don't think we've got any more questions. So once again, the hospital's done a fantastic job and they've arranged a GP appointment on discharge. So she comes to see me. She's not needed any more Ventolin, but she's now on Alvesco. So for those who don't know Alvesco, it's a fantastic option for this age range because it's once a day, so increases compliance. The only thing is it has a circular insert. So if they're using it with a spacer, you need to make sure the spacer has a flexible silicone entry point, not a fixed plastic one, because it won't fit in a normal spacer, but it's a great option. And the parents are saying they want to know if that's her now. They're terrified. She's always had mild asthma. Their fear was always the allergies, but now she's been in hospital with this thunderstorm asthma event. I mean, who would have thought it, right? They want to know what she's going to do. Will she have worse allergies now? Is it going to affect her egg allergy? Is she high risk forever? Do they need to get rid of her cat? And how long she needs to stay on nasal steroid and antihistamine? So does anybody have any thoughts about that? Anybody want to say what they would discuss here? Oh, Anna Marie's asking if the education policy extends to before and after school settings. Very good question, Anna Marie. We might have to ask, I think we've got some people from the Department of Education here. If anybody knows that and can put it in the chat, I don't personally, but it's a question we can take to them. Okay, so what I went through was, as we said before, Alvesco is a preventer. She clearly is a atopic allergic asthma kid. She was really well during spring when her allergies were managed. Unfortunately, this has been a thunderstorm asthma event, and anybody who works in Melbourne during these events knows that it is a natural phenomenon that is unprecedented and unfortunately flares people's asthma symptoms. So I said to them, it's now, I think, November. I said, we'll be on it for 3 months and we'll reassess. If she's got absolutely no asthma symptoms, we're heading into autumn, we can probably stop it. But my strong preference would be having a very low threshold to start it in September. I find all my patients start to come in with allergic asthma. However, what I would do first is the minute spring starts and the hay fever starts, she is on the antihistamine and the nasal steroid. I'm very clear that's 6 months of treatment for us in our area, beginning of spring to the end of January, even February. I'm still seeing allergy patients. It needs to be taken daily. It is safe, it is effective. Nasal steroid has no long-term issues apart from maybe a little bit of blood when you're blowing your nose. but we really don't need to worry about steroid load with nasal steroids. No, they don't need to get rid of the cat, but she's not had any symptoms towards it. No, we don't need to do a blood test to see if she's allergic to her cat. And we educate about thunderstorm asthma. So a bit of education about thunderstorm asthma. We explain that it is a rare event due to weather and pollen systems, that it is not every thunderstorm, but we do need to be wary on days where thunderstorms are expected. It's not waiting till the storm hits. Again, if you're all in Melbourne, the winds that come before the storm, when the weather changes, that's when we're going inside. If we're in school, we're going inside. If we're in daycare, we're going inside. And when it says triggers in the asthma plans, thunderstorm asthma, and sometimes I'll attach a little bit, there's not much room on that, I'll attach advice about thunderstorm asthma and saying, for schools and daycares to download the Melbourne, and parents, the Melbourne Pollen app and the Vic Emergency Services app. They will both give you alerts for thunderstorm asthma warnings in your area. However, no system is perfect, and we definitely had a thunderstorm asthma event this year that just wasn't picked up because the weather changes quickly here. So really noting that you're going inside on those high winds, you're turning on any recirculating air cooling that brings air from the inside, and crucially, for those who require a preventer significantly helps prevent against thunder asthma events. In the big one back in 2017, almost everybody affected was not on a regular preventer therapy. So really using it as a linchpin to explain to parents that if they are symptomatic, the best thing they can do if they're worried about it is have their child taking the preventer regularly. And that's why something like Alvesco is a great option, because it's just once a day. Okay. Slightly conscious of time. I think we're going okay, but we'll get on to case study 4. Okay, so this is a wee 12-year-old girl who comes in from interstate saying she's about to start a new school and she needs an asthma plan. So she was diagnosed preschool with wheeze and viral infection. She said she's had a few courses of oral steroids between 5 and 12 for wheezy episodes in the community. But her last exacerbation was 5 months ago, where she went to ED and she required steroid, oxygen, burst therapy, but she was discharged after 2 hours. This is interesting. So we've got no clinical notes. She's never been given a preventer, and she just uses Ventolin as required at the age of 12. And she's got home pred mix. She's been given home pred mix to use when she gets bad. So over the last few weeks since she's moved, she's had increased Ventolin use. She's using it several times a week. She's waking at night tight-chested. And since she moved from her high school last year, she feels breathless, she's gasping, she's lightheaded, and she says, crucially, she can pass out. It can be so bad. She doesn't cough, but she thinks she does feel that she's wheezy, or she can hear a funny sound when she's breathing. Her past medical history, she's got a cat allergy, rhinitis, complex PTSD, and childhood sexual assault. She's got anxiety with multiple somatic symptoms, and she was recently started an SSRI by her paediatrician up north. She's moved 5 schools in 7 years. Any further questions for this asthma plan? So someone's put, is puberty prompting the changes? Do you mean in the asthma or just in her presentation in general? Can I ask? In asthma. Shiv, I'll lead you to that. Does hormonal change asthma?
Not really. Sorry. Anyone's asthma can change at any time, and I guess sometimes we don't have good explanations for that. So I think there are certainly people whose asthma can get worse coinciding with, puberty, but I wouldn't, it isn't the first thing I would think of. Yeah.
Everybody's doing my job for me. Brilliant. Anxiety, emotion triggers, panic attacks,
Yes.
anxiety, asthma. If we control the asthma symptoms a bit better, it may assist with controlling anxiety. 100%. Is Victoria still considered one of the highest rates of asthma, Shiv?
Yes. Yes. Yeah, it is.
I feel like Truganina is specifically the highest rate of
Oh,
asthma.
specific, yeah, one of the reasons why why this has been established is that the Northwest, so including Truganina, has one of the highest rates of asthma admissions in the country by local government area. So yeah.
We've kind of missed out the bit about safer care, but this is part of a wider project commissioned by Safer Care looking at why the rates of asthma in the northwest of Melbourne are so high. That includes looking at population, looking at other environmental triggers, looking at pollution specifically. A lot of work has gone into that, and then creating various things to support people in asthma. And one is the community of practice, which we are all doing just now. We've been running for about 2 years now. So I'll put in the next step. So this is a kid that I felt exactly the same. This is a complex kid. Again, this is not a 10-minute consult, but we need an asthma plan and we're going to school. Now, how much is asthma? How much is anxiety? I'm strongly thinking a lot of this is anxiety. You don't go to ED and have oxygen for 2 hours and then you're discharged. You don't pass out from asthma. But she's definitely got asthma because she's been going and wheezy. So what do? I'm not going to necessarily start in a preventer because I'm not sure how much is recurrent acute asthma. But at the moment she's only taking Ventolin, and the current GINA guidelines say 12 and over, so adult populations 12 and over should be on a Symbicort type medication. Okay, so a combined ICS-LABA. That is to be taken as required, so in place of that as required Ventolin you'd usually prescribe, and to be used twice a day if they need preventer treatment. So it's exactly the same for those of us who work in the adult population as the SMART therapy we use. So Symbicort twice a day and then as required. We're doing that now for kids as well. So the premise is that asthma has an inflammatory component that causes microscopic changes in the airway, inflammation. So if you are having symptoms, it is not simply bronchospasm that needs relieved by beta agonist. It is something that has an inflammatory component that needs a small dose of inhaled steroids, even if you're just using it once or twice a month or pre-exercise. So as a good midpoint, I said, really, let's ditch the Ventolin. Here is a Symbicort turbohaler. So again, you don't need to carry a spacer to school. Showed how to use the turbohaler. Much less stigma about carrying a turbohaler to school for a teenager, much more likely to use. We have a brilliant teenage client who often contributes, who says she has never once seen anybody use a spacer at school. So yeah, we love turbohalers. They're better for the environment, they're better for patients, and they're just as good. So we start SMART therapy. I refer to the community asthma program. What a surprise. Because again, they've got a lot of time to help sort of nurture and go through with this young girl. I do the asthma plan, but we do it using the Symbicort for schools. So 1 puff as required. We're not doing regular therapy at the moment. We get her back. We do a care plan a physical care plan for all her physical needs that we've discussed, and crucially a mental health treatment plan. She's never really had consistent mental health support out with the court setting. The pharmacy reviews, so I employed the DMMR for those of us working in general practice because she's just started an SSRI and she's had a new inhaler. That's a lot for a 12-year-old. So we've got a pharmacist to go into her house and sit with her and explain and go through it, go through side effects, go through how she's feeling with it. And we've referred her to Headspace for house psychology. And also I referred her to the RMH for some psychiatry input due to other things within her history, and for pharmaceutical support. Some of my patients I will start an SSRI in that I know well in this age, but I do like to have them under pediatric or psychiatric support for the first year as well. And it just depends how much pediatric psych you do. I do a lot, so I'm happy to manage it, but I do like to phone a friend in those situations. And we reviewed it at 6 weeks and she had no asthma symptoms. So she's been on our SSI for 6 weeks. Her anxiety is significantly better. It's not gone. She's still got a lot of complex problems, but that acute anxiety is much better managed. She's felt hugely supported by the community asthma nurses and that she can access them. And she's felt like she's moved and made a change, and this is going to be some stability in her life. So as people said, it was much clearer to manage her asthma in ongoing years because her anxiety was well controlled, and she was much clearer about what asthma was and what a panic attack was. I've missed some of these questions, Shiv.
No, there was a really good question actually from Deb, which was for the school nurses, like how familiar are the school teams with using a Symbicort as a reliever as opposed to Ventolin? And I think Jocelyn said need more education, but yeah, I guess I think that's a really good point, because we would, in terms of what we consider best care, every 12-year-old and over with asthma would ideally be using Symbicort to relieve their symptoms. And it's very different because you just have one inhalation and then wait to assess treatment response, as opposed to having like 12 puffs of Ventolin. So, and we're really hoping to drive that. But yeah, anyway, so any other, if anyone else would like to come off mute and comment. Megan said one issue was people not having access to Symbicort. So yeah, 100%. And I would say that, yeah, if Ventolin's the only thing available, please use the Ventolin. I hope I want that message to be clear, but hopefully we can drive it so that more people with have been prescribed Symbicort by their whoever's looking after their asthma, and then can leave an inhaler or carry an inhaler on their person or in the school. The kids leave it somewhere, or the one they left at school goes, okay, yeah, and then it's staying in date.
Yeah. And I think that's a really important point. There's nothing wrong with Ventolin. Ventolin's not bad. We're talking about the more chronic day-to-day care. If a kid happens to have an asthma attack at school, school staff are familiar with Ventolin, they're trained in Ventolin. Things take time to change, and this is a relatively new change. So if you are working in the school sphere listening to this, don't necessarily be asking the kid to go and check their bag and find the Symbicort. If they're in the school nurse's office having a Ventolin and having an asthma attack, and you've got Ventolin, use the Ventolin. And we say that at home as well. If you've lost your Symbicort or left it at school, but you've got a Ventolin lying around, use the Ventolin. And it can be clunky, with the two methods of education, but most asthmatics are familiar with Ventolin. We're saying as things change, we're moving towards Symbicort for the chronic management, and brilliant if you've got it for the acute management. And I believe, Shiv, there's not evidence for the under 12s yet, but it might be heading that way as well, that and more we're starting, even as Shiv said, in the 2-year-old age range, these combined therapies. They are humans with human physiology, and things are slightly different, but it just takes time for evidence and data to come out for us to be sure to make those changes. All right, last one. I think we're on track if I can get my mouse to move. So this is our brother. He comes in the same day asking for an asthma plan. He was diagnosed with preschool asthma and wheeze and viral infection, and he's used his Ventolin as required, never with a spacer. But not really for a year. He's never had admissions, there's no steroids, no antibiotics, he's never had a preventer. He's been self-managed with Ventolin since the age of 12 at school. He's just always been given a Ventolin by his GP every year when he goes in for his asthma plan, and he cracks on. So reporting increased use at school. Now he's changed school, especially during sports. He says he's breathless after a few minutes of running. He gets a tight chest, but he's not coughing. He doesn't really know if there's wheeze again, maybe a funny sound. He takes the Ventolin when he's breathless, and he doesn't know if it's helping or just stopping running is helping. And he reports his main exercise is rugby, but mum reports he hasn't actually played rugby in 2 years. So his past medical history, he was diagnosed with ASD level 2 age 7. He's got anxiety, he's got NDIS support, he has a history of childhood trauma, and he's got hay fever with rhinitis. So a 14-year-old with a lifelong history of asthma, who's really not had any symptoms in years, but he goes in every year for the asthma plan required for school, and he gets a new Ventolin and a new plan, and off he tots. And since moving schools and doing sports again, which he's not done in a while, he's getting breathless. Any further questions or thoughts? Vape use, brilliant. Well done, Jocelyn, you're up to date. No, something I always forget to ask teenagers about because I'm not with it. But excellent question. Is he using vape? I'm going to leave that for a different, maybe we'll use vaping at the next community of practice. We've been meaning to. So, but no, he's not vaping. or using any other drugs? Lisa, need to reassess the asthma diagnosis. Yeah, 100%. So how are you going to do that? I'm not going to pick on you, Lisa, but how would you do that? How would you know? You're not at school with them, you're not seeing him. What are you going to do? Response to Ventolin. Yep, so is it actually working to Ventolin? Okay. So what I did and what I said to spirometry, yep, brilliant. Use of a spacer. No, he doesn't use a spacer, he's 14. Far too much street cred, doesn't want a spacer. Deb, spirometry, brilliant. Okay. Okay, we'll move on to the next bit. So this is what we did. I sent them to the community asthma program. I said it's a free service. They're brilliant. Phoned a friend so they could see him a bit more. This family just needed support in every sphere as well. So we got his hay fever under control, first of all. So he does have allergic rhinitis. So I was like, right, that's an easy win. Let's get you on a nasal steroid and antihistamine. I did an allergy plan, allergic rhinitis allergy plan for school. And I did an exercise test and PFTs. So we sent him for PFTs, they were normal, and an exercise test. I think Shiv's heard my through to exercise test. So basically I say, go into the park with your mum and take your Ventolin. And we're still using Ventolin at the moment. I've not moved on to Symbicort because I don't think this kid's got asthma. So I say, start running. If you get breathless, stop. Mum, you're there, your safety net. If you think he's coughing and wheezing and really struggling, give him his Ventolin. See what happens, okay? But if you stop, and by the time you've kind of walked back to mum, you feel okay again, just hold out. And if it all settles down, start running again. Do the same thing, okay? Again, feeling breathless, don't feel you can push through, it's worrying you, okay, stop. Again, is there coughing, is there wheezing, does he look breathless, or does it actually look it's settling pretty quickly? Because if this is exercise, most kids who it's physical fitness, it settles pretty quickly, whereas asthma doesn't settle after a minute of stopping. And I'm not saying wait for ages with a kid who's gasping and wheezing and coughing. Obviously, give the Ventolin. If they have those symptoms, give the Ventolin. Does it go away? It's pretty crude, but I can't think of a better way of doing exercise-induced asthma. Schools are too busy. You can't ask that of a school and a PE teacher. And parents are invested and they're pretty good at assessing their kids and whether they're panicking, whether they're breathless, or whether it does look like asthma. So he's not alone just wondering about it. And we did the exercise test and mum said actually he ran a bit further than he thought he could, not in the school environment. And he was breathless, but he stopped and it sort of settled itself. So we kept on doing it a few times and he didn't need to use the Ventolin. So I felt this was no evidence of asthma. But this kid has just come into my care, right? This is maybe the second or third time I've seen him. And we had done an asthma plan so he could go to school with his Ventolin. And I said, I'm not going to rescind it just yet. It can stay there for a year while we monitor and while we look at things. And then next year, will write the letter saying, if he's had no exacerbations and still not using it, he doesn't have asthma, he doesn't need an asthma plan. We're going to de-diagnose this kid. So, yep, he understood more about his physical fitness and limitations and gradually increased his exercise tolerance. And he didn't have any further Ventolin use. And actually, 6 months later, I wrote a letter to the school saying he doesn't need it. And then he came in, just after I wrote these slides, actually, he came in and we were chatting and I said, oh, how's the rugby going? Because we'd had a bit of a laugh about it, the fact that he said he was playing rugby, but hadn't actually. And he launched into it. He was like, brilliant, I'm in the team, blah, 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 and rattled on about his rugby. And as he's left, his mum said, do you know the difference that made, him not having asthma? He's a kid who's got complex, horrible life syndrome, awful trauma as a child. He's had this label of scary asthma. He also has autism. So his sensory processing and his understanding and literal taking of things when you gave him information is really difficult. And then he was moving school. He missed playing rugby. That's what got him social connection. And once he had been de-diagnosed and told, actually, it's just your fitness, you need to get up and go for it, and you're fine. he had rejoined the rugby team and it was life-changing. He had a social circle, his anxiety reduced, he didn't feel so labelled with his ASD because it didn't impact his rugby playing, and it really de-diagnosing and really changed his life. So I would encourage people to be confident, to be really clear on de-diagnosing. Yes, lifelong risk. If you come back when you're 30 and you've got asthma symptoms, it'll be your asthma again, but at the moment, we're not worried, you're okay. Someone saying if parents can't reliably assess, could have physios or something. I've never referred to an exercise physiologist, so that's another thing you could do through a care plan, refer to an exercise physiologist. Shiv, we'll move on to Shiv's slides about exercise-induced asthma, and maybe he can tell us if there's other allied health professionals that can help us.
Great. And so, yeah, one of the common things that comes up around school and returning to school is the idea of exercise-induced asthma. So we're just going to touch on that for a bit. And I think if we go to the next slide, I think we start with a poll question. So hopefully we can launch that. And so I'll just read it out. So which of the following can be helpful in determining if exercise-induced shortness of breath is due to asthma? And there's a few options there, and we'll give you a bit of time to answer. And Megan, I'll answer. So if I wasn't sure, in terms of making the diagnosis, I'd probably refer them to a lung function lab for an exercise test, and we're about to talk about what that is. I guess and so that could help you work out if it's asthma or not asthma. And so and then if it's not asthma, maybe you could get the help of a physio or an exercise physiologist to work on fitness. But in general, kind of I leave that to families to do themselves, because once you've given them clarity about the diagnosis, then often they'll go off and do it. And I'm not sure how people are going answering the question. And then in terms of diagnosing asthma, the next question, in general, you can diagnose it based on history and observed response to asthma therapy. So, you know, if you have someone who's got symptoms of asthma like wheezing and respiratory distress and you give them Ventolin and they get better and that happens repeatedly, then that's enough to diagnose asthma.
Not sure polls work.
Oh, there we go. Cool. So yeah, okay, well, this is a great group because 83% of people have gone all of the above, which is exactly right. So I'll just talk a bit more about that in detail. So if we go to the next slide, if someone has shortness of breath, Kirsty, would you mind going to the next slide, please?
Yeah, sorry.
Oh, that's right.
Me.
Yeah, so if someone has exercise-induced shortness of breath, asthma can certainly be a cause, but if we go to the next slide, there's also lots of other things it can be. So I'm not very fit at the moment, so if I run, I get short of breath very quickly. Also, you know, with regards to anxiety, when I'm anxious, I tend to get quite nauseous, but for other people, shortness of breath can be a manifestation of anxiety. And there's also certain other airway-related problems like vocal cord dysfunction or laryngeal dysfunction that can cause exercise-induced shortness of breath. And so I thought I'd just talk you through, I know this is a very busy graph, but slide, but I'll kind of explain what this is. So in relation to your question, Megan, we can do exercise challenges in the respiratory function lab. And so what happens is a child comes in and they do lung function, so spirometry just at baseline. And then they run on a treadmill for like 10 to 15 minutes at least. And we're trying to get them to run somewhere near their maximum heart rate. So based on their age, we calculate the maximum heart rate and then try to push them on the treadmill until they're running for 10 to 15 minutes of maximal heart rate. And then afterwards they stop. What we do is we do some lung function a minute later, and then 5 minutes later, and then 10 minutes later, and then we can do them 15 minutes later. And what we're looking for is if there's any change in their lung function. And so this patient here actually has the typical illustration of what happens with exercise-induced asthma, which is that if we just focus on these loops, so a smaller loop indicates that they have more active asthma. And so the baseline values are the biggest loop. And then the one that's done immediately after exercise, which is red, is a little bit less. and then green's even less, and then orange is the lowest. And that's kind of reflected in this graph down the bottom here and in these numbers here. So 1 minute after exercise, there'd been about a 2.7% drop in FEV1. 5 minutes after exercise, there'd been a 5.5% drop, and 10 minutes after exercise, there'd been an almost 15% drop. And you can see that in the graph here. And so what this kind of tells, this is the typical pattern of exercise-induced asthma, which is that one, you have to be exercising for some time to trigger the inflammatory response that causes exercise-induced asthma. So it doesn't happen within the first minute or so. You have to kind of exercise pretty intensely for about 10 to 15 minutes. And then two, it actually gets worse afterwards you stop exercising. So if you stop exercising, you might have some symptoms, but it will likely get worse before it gets better. So in this patient, over the next 10 minutes, it progressively got worse and worse and worse. And then they were given some Ventolin and their lung function improved back to above baseline. So that's the third characteristic, is Ventolin is very helpful. But all of those things, so needing a significant amount of exercise and time exercising to trigger the symptoms, and then the symptoms getting worse after you stop, and then responding to Ventolin, those are all what help confirm the diagnosis of exercise-induced asthma. Kind of as Kirsty was saying initially, with her last case presentation, if the symptoms start very soon afterwards exercise starts and they get better quickly, it's unlikely to be asthma. So if we just go to the next slide, this kind of is the a table that kind of summarizes it. So the duration of exercise prior to symptoms starting, what happens when you stop, how long the symptoms last for when you stop, and how much Ventolin helps. And the predominant symptom being wheeze, as opposed to what you sometimes see in other conditions. The one little caveat I'll explain with the asterisk next to effective bronchodilator under other causes is that Ventolin or a bronchodilator like Symbicort will not help the other causes like fitness or anxiety at a pharmacological level, but often the act of stopping and controlling your breathing to take these medications might be helpful. And so it's kind of like the placebo effect. So that you just have to keep that in mind with using that effect of bronchodilator as a criteria. So I know that's been quick, but hopefully that is a little, that's helpful for diagnosing exercise-induced asthma.
Thanks so much, Shiv. If anybody's got any questions about that, just pop it in the chat. I'm just going to quickly answer a question here about de-diagnosing asthma. I don't know how much you do this, Shiv. I suppose you might see a lot of people who you say it's not asthma. For me, and my patients that I know well, I would say the process usually works out to be over 2-year cycles, because for the mild asthmatics who are just on Ventolin or as required Symbicort, it's usually I haven't seen them, they've not used it, they're coming back for a school asthma plan, and I'm doing a full asthma history, which we'll go into in the asthma action plans, which I'm sure you all know, and they're saying, oh, we've not really used it. And for me, that's like, oh, okay, maybe you've gone out of it. But if I've not seen a child and I've only just refreshed the asthma history, or I'm giving it for the first time if they're a new patient, probably not confident enough to say, oh, no asthma, no Ventolin use for a year, that's it, fine. I sort of then talk about the process of de-diagnosing, review when you should use asthma inhalers, when you shouldn't use them, if they're unsure to come in again, to start coming in again, so I can hear, oh no, it's not wheezy actually, it's just a cough and a cold, you're right, you don't need your Ventolin, to think about exercise. And if when they come back at the next year, they're like, I haven't used this, I'm happy to write a letter to the school saying, like, this isn't asthma. And I find that works for the seasonal asthmatics as well. 1 year without allergies, I'm probably not going to de-diagnose you. I probably, because it's Melbourne and because of thunderstorm asthma, the ones who are particularly atopic, I will say to them, you've probably gone out of your asthma, but I don't stop their asthma plan for school because of thunderstorm asthma. So I explain you're probably not asthmatic, but if you're severely atopic, still suffer from very bad allergies like hay fever and rhinitis and seasonal allergies, and you're still anaphylactic to egg, your threshold's just up there, your risk profile's higher. So I personally would just let them have an inhaler at school just in case, because having worked the first well, actually all the thunderstorm asthma events now, but the first one, I had about 17 people arrive on our doorstep at once, overwhelmingly unwell with asthma. And it's hard. It's really hard treating 17 asthma attacks in the community at the same time. And the thought of that happening in a school, and school staff or school nurse, if you have a school nurse, having to manage that, then a kid who doesn't have an asthma plan but is symptomatic, possibly with a bit of cough coming in, and then them trying to panic and say, am I treating you? Am I not treating you? I just think it's easier if you keep the awareness of thunderstorm asthma for those atopic and seasonal allergy kids. I don't think through all our discussions we've had the specific guidance on that. I just personally feel more comfortable for them, and that's probably from where I work and my experience. What do you think on that, Shiv? When would you de-diagnose or be comfortable to say absolutely no need for an asthma plan for school here?
Sorry, I apologize. I misread your question initially, Nilpli. Yes, exactly what Kirsty said. I probably, in someone who genuinely had asthma, it would be about a year or so. Occasionally I see someone right from the start who I think has just been misdiagnosed, and you can take away quicker, but otherwise, yeah, at least a year.
And Amy's just saying Montelukast prescribed for exercise-induced asthma.
Yeah, that was like very in vogue, a thing to do in the past, and it's still a reasonable thing to do if you're convinced someone has just exercise-induced asthma. I will say that in the 12 and overs now, I tend to just go straight to Symbicort, and they can just take that pre their exercise, and then they can also use it as a reliever if their symptoms occur during exercise. And the other problem is, all the behavioral stuff with Montelukast. So it's not something I do in practice, to be honest.
So I'll go through the asthma plans, asthma action plans. I'm sure everybody knows how to fill these in. It's just to show the most popularly used ones. We had an asthma symposium back in September, and everybody actually found it really useful just practically going through them. I do see a lot of variation in how these are filled out. So for everybody working in the education centre setting and healthcare setting, this is kind of what we're expecting. So I think this is actually a slightly older one, but it's roughly the same. So name, plan date, doctor details, and review date. Review date does not need to be a year in advance. That's the clinical review date. So if you have one of these mild asthmatic kids who use their Ventolin a couple of times a year, consider whether they're actually needing it. Is this a de-diagnosis? So those are the kids that I'm thinking, oh, let's have a chat about asthma. Next year we might be de-diagnosing you. And if they do, fine. If they're stable and it's very occasional, put the year review date. Anybody with a new diagnosis or active clinical review, I'd be making that much, much shorter, in line with whatever you feel at the time is the clinical date. Now that comes into problems with school, because if it goes over, because everybody's busy, parents are busy, schools are busy, doctors are busy, you get the parents in saying they cannot come to school because their asthma plan is in date. Really tricky. As we said before, not true. Children cannot be excluded from an educational setting. So that is kinder, that is school. We need to clarify about long-term daycare and before and after school care. If it's attached to the school, that would be the same, but other settings, I'm not sure. They cannot be refused access if the date is gone past. You may have noticed in a lot of the allergy plans, it now says this plan does not expire, but review is due by. We've been working with Asthma Australia and the NEC to see if we can get this, but for various reasons, it's not there yet. But I think that helps add clarity for schools. And then you're putting in your preventers and relievers. Everybody knows what to do here. So just to confirm, for preschoolers, the preventer is Flixotide Junior. The reliever is Ventolin. The Ventolin is 2 puffs. For a flare-up, we are not increasing the inhaled corticosteroid for the preschoolers. For the under 6s, there's no evidence for that. We are just taking the same dose of Flixotide, and the reliever is 2 to 6 puffs as needed. And we are not starting oral steroids. We haven't gone through this, but there is no evidence for oral prednisolone in the community for the under 6s. I'll say it again, new change, might be new practice to people. There is no evidence for oral corticosteroid in the community for the under sixes. The evidence for oral corticosteroids is to prevent ITU admission. If you're giving medication in the community, and this is how I explain to parents, to prevent ITU admission, they should not be in the community, they should be in hospital. So it's 2 to 6. There is no other medication here. We are not increasing the preventer. For severe, we are keeping the preventer the same. We might be reviewing the asthma plan after this and increasing the preventer, but we're not doing it short term. We're taking the reliever, 6 puffs as needed, okay? We're not starting other medication. We are seeing the doctor. Now, between these two is the sort of fear points for the parents. And what I'm saying to them is, if your reliever medication is not lasting 3 hours, it's 2 hours. It's 2 a.m. Your child has woken up. You have given them 6 puffs of Ventolin via spacer. Your clock is now starting. If they pull through to 5 a.m., that's 3 hours, and you're an experienced parent who's not scared by this and you're happy with your child's clinical condition, you're giving another 6 puffs, you're waiting 3 hours, and you're driving your child to the GP surgery and saying, see my child, okay? Or you're calling the Victorian virtual ED and saying, I need a bit more confidence and advice here. If you start that timer of 6 puffs, 12 if it's an older child, at 2 a.m. say, and in an hour they're needing more, you're giving the burst therapy again, packing a bag and heading calmly to ED. 2 hours, calmly to ED. Only if it's lasting 3 hours that I'll tell my experienced parents who are not worried and scared by this, you can stay at home till the morning, you're coming to see me, or you're calling the Victorian virtual ED if you're in the severe category. Emergency. We don't want kids to get to an emergency. We don't want them to be puffing and going, it's not working at all. Okay. And previously, the action plan went from severe, not lasting 3 hours, straight to emergency. There was no guidance. So I'm really clear on parents on that. If they are not stretching 3 hours on maximal therapy, if you're comfortable, they're coming in first thing in the morning. You're not waiting a few days for an appointment. You're just saying my kid needs to be seen. Or you're calling the Victorian virtual ED and going to their asthma clinic. Don't know if anybody's said anything about that. So for the older kids, it's up to 12 puffs. It's not 6 puffs, okay? And if the 12 years and older, we're on Symbicort, so preventers, Symbicort, relievers, Symbicort, preventers, Symbicort, relievers, Symbicort. And it's 1 or 2 puffs depending on the severity of their asthma. And the guidance on up titrating and down titrating, all of these inhalers is on the RCH website and Health Pathways. We just don't have scope to go in for it today, okay? Now, what do you do if the school says, sorry, they can't come in? We had a really productive meeting with the Department of Education. I would encourage you all to screenshot that email at the top of this slide. Parents and schools can go to for health policy advice and clarification. I previously had a set piece letter that explained asthma plans do not expire. The review date is a clinical review date. That does not mean the child cannot go to school. They're not allowed to be excluded from school. But what do I know? Lots of schools don't listen to me. So now we can just use that email address to state and say, if you have any further questions on this, I encourage you to use this email address. And the parents can do that for you as well. You can get the parents to advocate and be proactive and tell the school, actually, that's not what I've been told by my healthcare professional. I want you to email to provide further clarification. The Department of Education felt very similar to us. The same problems come up, that these plans are out of date, they're not reviewed, people don't have inhalers. It's very hard for schools to keep on top of it. But the whole reviewing every year, I'm sure clinicians here get the I need a new asthma plan because it's the beginning of the year. The actual policy outlines that student health plans for any kid with any illness need to be updated annually by the school. That is their responsibility. They have to update their healthcare plan and make sure they have reviewed that policy every year. That does not mean our healthcare plans, like an asthma plan, an epilepsy plan, an allergy plan, needs to be reviewed at the beginning of the school year because it's the beginning of the school year. If it's in date, if you've got a new patient in December and you've put the review for March, They do not need to come back in January for a new plan date. That plan is valid. And again, if it expires, the child cannot be excluded. They just need to come back for a clinical review because of their clinical need, okay, not because they need to get to school. And I think the more we sort of message consistently and clearly, it's just really difficult to get a unified message across multiple agencies, multiple healthcare professionals, multiple schools, who across the private sector, the public sector, the religious sector, everybody interprets guidelines. And the Department of Education made a really good point. You can be as clear as you want, people still interpret it differently. But if you're here tonight, feel very confident, use that email address, signpost, the child cannot be excluded for school. And specifically for fee paying kinder and daycare, people are being charged and the child is being denied access to the kinder. And in my area, that's a really big deal because a lot of my patients, if they don't go to work because they're looking after their kid and then coming in, we don't charge for kids, but some areas they're paying for an appointment as well. That's an expensive day. No income for the day, no paying childcare, and they have to pay for a doctor's appointment. So it's really important that we get this message across. It's the parents' care's responsibility to provide the child's asthma care plans, obviously, not yours, it's schools. So some autonomy needs to lie with carer, but I think everybody's aware of that. And I think we've gone through everything else, but it was really productive, and we hope to have more engagement with the education sector to kind of iron out some of the other issues, such as what Anna Marie put in the chat about whether this extends to after and before school care. Any questions? I think that's it. Okay. Right, we've got 2 minutes left. Astonishingly, we are on time. So just a little bit about health pathways and the Melbourne Community of Asthma programme. We've rattled through loads of information. A lot of the things that people may be asking or thinking of or not wanting to put in the chat is covered in the health pathways guidelines or in the RCH clinical guidelines. So when do I up titrate? When do I down titrate? What were they talking about Symbicort? How do I start that? All this information is covered in health pathways. I know for people who use health pathways, sometimes you reach a dead end, especially with looking at referral criteria. This is actually a really good resource. And sometimes my brain goes into a little bit of a spiral and I go, oh, what am I doing here? And I check it too. So you go to respiratory, child, asthma and children. There's acute asthma. So again, if you get an acute asthmatic child in and you're a bit rusty, maybe you don't see that many kids, and that's why you've attended tonight, there's actually how to manage acute asthma there. Asthma in adolescents, primary school age children, it's all there. Okay. And going on to this one. That's all the different pathways that you can use. Anaphylaxis, allergy, it's all there. And the Royal Children's has a very similar resource if that's what you use. And then we've talked about the Community Asthma Programme. It's DHHS funded, so CoHealth, Laverton and DVP. How do you refer to them? I should say that Asthma Australia asthma plan is now embedded in the best practice, as is the Community Asthma Programme referral pathway. So if you're using best practice, go down to C when you're searching Community Asthma Programme, the referrals in there. Otherwise, if you Google either of these centres, you'll find their details and you can make a referral. Free referral, they're seen in a really timely manner, usually within a couple of weeks. They are incredibly useful for gathering more information, brilliant communication, and I find them invaluable service. And on that, we have a little poll just to ask if people are using them and how much people are using them. So if I could ask you to just say if you've used the Community Asthma Programme, no, but it sounds like a great idea, you want to, or no, you're never going to use it. Good. That's great. That is good. Almost everybody going to use it. And Deb just saying, yeah, still a lot of people prescribe Flixotide at the beginning of cough and a cold for 3 days and then stopping it. There's no evidence. It doesn't really do anything. And oh, Anne-Marie has very helpfully put, you can self-refer as well. So if you have your own asthmatic child, or you have you're at the end of a really busy consult and you just don't have time to refer, you can give them the details and they can phone, parents can phone and self-refer to that service as well. Okie doke. And that's us on time. Which hardly ever happens again if you're new here. So your feedback's really important. I'm going to show one of those little block things. If you could do our survey to see if you found this useful, to see if it's something that we're going to run again and keep including the content. If you would like particular things shared or discussed at the next community of practice, which will be in May, please do say. We were thinking of doing a summary of all the important findings and topics we've covered over the last 2 years via case studies, basically. So we'll have case studies incorporating the topic, and then we'll have specialist speakers speaking to that point, stats and evidence related to it. So if there's particular topics you would like to be covered, please do, and you can sign up to the ICAM Community of Practice Basecamp to keep up to date with all our information. And that is the QR code. That's what it's called. A lot of people as well, we just haven't quite chatted about the high rate of asthma in the West. Yeah, there's a lot of thing about air quality and pollution. I think the building work has definitely affected it, not just the drying out of wetlands, but the quality. If anybody's related to a builder, this is absolutely no judgment, but the quality of building materials and what's in the building materials that's been popped up in very quick builds. There is definitely a interesting taste and smell to the air some days, especially when there was the big growth. I've been working in Trig for 10 years. There's a lot in the air out there that is very triggering, but it does extend from that area all the way to the inner west suburbs, which have huge numbers of asthma and allergy as well. Okay, so our next community of practice, put it in your diary. You'll get messaging from the PHN if you've signed up to the newsletter. Wednesday, 28th of May. As I say, if you want us to cover anything in particular, that's great. We're really responsive. We love getting suggestions. And it's 6:30 to 8. Yes, you can register for the Paediatric Asthma Care Masterclass that Shiv is hosting as well if you click on that link. Oh, there's also an Asthma Australia competition, which we need to let you know. If you go onto Asthma Australia website and look for the Be Ready back to school, you can win one of 20 air purifiers. So again, if you have asthmatic kids and want to win an air purifier, you can enter, or you can signpost it to your patients who are looking for air purifiers if they have children